Hi, my name is Aaron Gerds, and I'm an associate professor of medicine at the Cleveland Clinic and Case Comprehensive Cancer Center. Myelofibrosis-associated anemia is a really big issue in the world of MPNs for a lot of reasons. The first reason is myelofibrosis-associated anemia is prevalent. 40% of patients will be anemic at the time of presentation, and then over the course of one's disease span, they will almost always develop anemia. So it's something that touches almost every patient who has myelofibrosis. It's also important because it's very prognostic. We know that anemia is associated with worse outcomes for patients with myelofibrosis. And not just a simple association, but actually there is a dose response curve. The worse the anemia, the worse the anticipated survival is for that patient. So we can say that patients who are heavily transfusion dependent have a much worse outcome than patients who don't have any anemia at all. And there's everything in between that spectrum. Lastly, myelofibrosis-associated anemia is important because it is multifactorial. And by multifactorial, I mean that there are lots of different causes that relate or lead to anemia in patients with myelofibrosis. It could be ineffective erythropoiesis due to heavy mutational burden. It could be ineffective erythropoiesis due to inflammation and elevated levels of hepcidin. It could be due to drug effect, like JAK inhibitors, lowering the hemoglobin levels. And it could be due to increased destruction through splenomegaly and even some autoimmune hemolysis. Being multifactorial actually makes it pretty difficult to treat. There's not just a one-hit wonder, a single kind of pathobiology we need to leverage in order to make anemia better in all patients with myelofibrosis. Therefore, we need multiple agents to attack this problem. There are a lot of different agents available today commercially to treat myelofibrosis-associated anemia. We think of two main categories. One are just straight anemia supportive agents, things like ESAs, erythropoiesis stimulating agents, luspatercept, and danazol. These are drugs that really just improve anemia in patients with myelofibrosis. We often use them in related diseases like myelodysplastic syndrome as well. And they really don't have any impact on the rest of the disease presentation or disease biology to the best of our knowledge. And again, we focus on using these drugs in patients who have just anemia and don't have overt splenomegaly or symptom burden. It can be used with or without JAK inhibitors, which I think is a very important thing to note. Just because a patient is not on a JAK inhibitor doesn't mean you don't have to address their anemia. And likewise, if a patient is on a JAK inhibitor and doing well, their spleen and symptoms are under good control, you can add on one of these agents safely with the JAK inhibitor to improve their anemia. The other major kind of category of therapy for myelofibrosis-associated anemia are the JAK inhibitors that also inhibit ACVR1. That is pacritinib and momelotinib. So by inhibiting ACVR1, they lower hepcidin levels, treating the anemia of inflammatory block. It's kind of a two for one, right? So with the JAK inhibition part of those drugs, you're treating the spleen and symptoms, but with the ACVR1 inhibition of those drugs, you're treating the anemia, the myelofibrosis-associated anemia. At least that's due to, in part, to elevated hepcidin levels and inflammation. Pacritinib also has this added benefit of being an IRAK inhibitor, and we know that IRAK is an important pathway in the NF-kappa B signaling, as well as in the pathobiology of myelodysplastic syndrome. So it kind of builds in our minds that pacritinib would be a good agent to treat cytopenic myelofibrosis, and of course, those patients have anemia as a central piece of those cytopenias. And that's all well and fine. I think we also really need to make a focus on what to do next, right? So these anemia supportive agents, the JAK inhibitors that treat ACVR1 or hit ACVR1, all can improve anemia, but don't do so universally. And what we really need to do is continue to develop new therapies that really get at the root of disease. The one treatment we have today that can absolutely reverse 100% the anemia associated with myelofibrosis is a stem cell or bone marrow transplant, an allogeneic transplant. And that really tells us that's where we need to go with treatments. We need to go to disease-modifying treatments, treatments that truly root out disease to restore erythropoiesis. Of course, this is going to have many other benefits for a given individual with myelofibrosis, but really, if we want to tackle head-on the problem of myelofibrosis-associated anemia, we have to develop better treatments that truly root out disease. And we can see evidence of this in developing therapies like pelabresib. So pelabresib in both the early trials and in the randomized phase 3 trial led to anemia responses by deeply rooting out disease, we believe. So really, that is the future of where we need to go with myelofibrosis-associated anemia. Of course, the anemia supportive agents are important today and will be important tomorrow. We continue to develop new agents that can do that, and I think that's incredibly important. But we cannot forget the ultimate goal of developing better therapies that really truly root out the disease that is myelofibrosis.